Dr. Laurel Kartchner, a medical science liaison with Natera, and today I'm going to talk to you about a recently published article from the Journal of Nephrology titled Expanding the Variability of the ADPKD-GANAB or GANAB Clinical Phenotype in a Family of Italian Ancestry. Autosomal dominant polycystic kidney disease is the most common inherited type of kidney disease. Typically, patients with ADPKD are going to have end-stage renal disease by the 6th decade of life. And ADPKD is a systemic disorder that affects both the renal compartment and exhibits extrarenal manifestations. In fact, in more than 80% of patients with ADPKD, they will have liver cysts developed by the age of 30, and there's also a wide spectrum of cardiovascular symptoms that these patients can have. ADPKD is most commonly due to the mutations in the PKD1 gene that comprises about 77% of ADPKD, and 15% of the cases of ADPKD will be due to mutations in the PKD2 genes. Now, there will be some subset of patients that don't have mutation in either of these genes, about 8% of patients with ADPKD. And among those 8% of patients, GANAB has been identified as the cause of ADPKD in about 3% of genetically unresolved families. So it's a relatively uncommon cause of polycystic kidney disease, but is the most common outside of PKD1 and PKD2. Typically, it presents in mild ADPKD and is often associated with liver cysts. In fact, in some patients, liver cysts are considered to be the prevailing phenotype. In this study, the group describes a family of Italian ancestry that had mild, late-onset ADPKD due to mutations in the GANAB variant. In the case under review, there was a 45-year-old Caucasian male patient who was diagnosed during a pre-surgical screening for an inguinal hernia repair. Serum creatinine was normal, as was eGFR, and urinalysis did reveal microscopic hematuria, but the patient had a negative family history in spite of the presence of cysts. Looking at the patient's history, in their 20s and 30s, they experienced a few episodes of urinary gravel emission or kidney stones. At the age of 45, the patient underwent umbilical and left inguinal hernia repairs. The patient also exhibited borderline hypertension and a mild aortic root dilation. At the age of 49, the patient underwent right side inguinal hernia repair. At the age of 51, the patient was admitted to the ER due to right flank pain. Ultrasonography showed grade 2 right hydranophysis related to a 7x5 ureteral stone. The patient also was identified to have acute kidney injury with elevated serum creatinine ranging from 0.7 to 1.4 mg per deciliter. There was a double J stent that was inserted to relieve the obstruction, and 2 months later, they performed a ureteroscopy to remove the stent and disintegrate the calculus. A CT scan showed multiple cortical renal cysts. The largest measured 4.2 centimeters in diameter, as well as a number of liver cysts. The largest was 12 centimeters. And the patient was also noticed to have sigmoid colon diverticulitis. After treatment, both the parents and the brother underwent nephrological screening as well to determine if this was specific to the patient or if this existed elsewhere in the family. Upon evaluation, no family members displayed renal function impairment, although both the 80-year-old mother and the 84-year-old father did have bilateral kidney cysts on CT scan. The height to kidney volume for the mother was 239 milliliters, whereas the height to kidney volume for the father was 435 milliliters. Neither of the parents had liver cysts, and the cysts were parapelvic in the father. The mother was reported as being on antihypertensive medication since the age of 55 and additionally had colonic diverticulitis at the age of 45. The father had a history of previous epididymal cysts. The brother, when evaluated at the age of 56, had no cysts present, and an 86-year-old aunt was shown to have bilateral renal cysts, no liver cysts, and normal renal function. Genetic testing did not detect mutations in the PKD1 and PKD2 gene. As such, the group decided to use a multi-gene panel specifically focused on genes associated with PKD. They were able to identify a missense heterozygous mutation present in the GANAB gene. And this mutation was identified in both the initial patient detected as well as the mother of the patient and the aunt, both of whom showed cysts as well. Mutations in GANAB have been associated with activity of glucosidase 2, which is a protein involved in protein folding that is present within the endoplasmic reticulum of cells. As such, the group believes that the mutations in GANAB that lead to polycystic disease are specifically associated with the polycystin 1 pathway. The group concluded that this novel mutation in GANAB was associated with mild ADPKD and a plethora of renal and extrarenal manifestations usually described in PKD1/PKD2 patients. And there's evidence that this mutation or mutations in GANAB can cause both ADPKD and ADPLD of variable severity, and that renal and hepatic cystogenesis are the result of common defective polycystin 1 pathway. Thank you very much for your time. Please feel free to reach out for any questions that you may have.